So, good afternoon. We welcome you to this quick poster session. Together with me is Maria Pina Chiruna from Naples. And we just start. And the presentations are only 1 minute, and we have 1 minute for discussion. So we have a very quick succession of presentations. So we'll start with the time with.
We start with outcomes of pediatric endoscopic pulmonary sinus treatment PEPSID systematic review. Dr. Montesecchio from United Kingdom.
It's another one.
Maybe we have to start with another presentation.
Okay, well, what we can do is we use this one, but at the second, because the colleague needs to leave earlier, we will do
the outcome of pediatric endoscopic pulmonary sinus treatment PEPSID systematic review.
You can do it, but they should prepare the second one.
Okay,
Yeah.
so the first one for laparoscopic excision of abdominal lymphangioma single center experience, Dr. Infantino from Florence, Italy.
Thank you. What we present today is our experience in abdominal lymphangioma surgical management. So, we retrospectively collected data about the patients who underwent surgery because of this rare vascular malformation in our center, Mayo Children's Hospital, in the last 10 years. We focused on the surgical approach and the surgical outcomes. We treated most of them with laparoscopy. Only 2 of them required conversion or a mixed approach, and 2 of them were treated with laparotomy because of bowel obstruction. We did not find significant difference in surgical time between the open and laparoscopic approach, and no major complications occurred in both of these groups. The laparoscopic group had no relapses and follow-up, while we had 1 relapse in the cohort treated with laparotomy and 1 with a mixed technique. We follow them, and nowadays all patients are doing well, and they did not require further hospitalization. So what we found is that in our hospital we prepared treatment with laparoscopy, and we only used laparotomy as an emergency setting. Thank you for your attention.
Question from the floor?
No question. I have one question. Do you think retrospectively you could have avoided a laparotomy? Retrospectively, you could have avoided a laparotomy?
I think that the 2 laparotomies were emergency settings, and the choice of the approach depended on the surgeon's choice of time. So this is our starting point. From now, we can try to make them all laparoscopies.
Thank you.
Thank you.
We move to the next. It's presentation 86. So we forward ahead. 86 outcomes of pediatric endoscopic. I don't manage to change it. Okay. So we just go in the right order. Next one is Bergmesh splenomegaly for 1-day massive splenomegaly.
So good afternoon. We want to present this case of a 13-year-old girl with hyperesplenism secondary to ochyrocytosis with a massive splenomegaly, 19.4 centimeters, that was diagnosed of a wandering spleen that was located in the pelvic cavity and that caused a gastric volvulus. So a splenectomy was not indicated. Splenectomy was planned. So after raising the spleen and the torsion of the stomach, a back mesh splenopexy was performed to a deperitonized area in its orthotopic position. So the postoperative course was uneventful, but 6 months later, she presented symptomatic cholelithiasis, so we performed a lab chole, and this allowed us to check how the spleen was, and you can see the dense adhesions all over the rim of the spleen. And after a 5-year follow-up, the spleen is still in place and the patient is asymptomatic. So we think that back mesh splenopexy with a window deperitonization allows for a steady and strong attachment, even in the case of massive splenomegaly. Thank you.
Any questions, any comments? Thank you very much for sharing these results and this interesting. Thank you very much.
Triple IA syndrome and esophageal atresia, minimal invasive treatment, 5-year single center experience. Dr. Donato, no. Okay.
Good morning and thank you. Triple A syndrome is an extremely rare hereditary disorder. Its early recognition is challenging given its rarity and phenotypic heterogeneity. It's worth noting that this syndrome can be life-threatening when misdiagnosed. So we would like to underline the key role of the pediatric surgeon in detecting this syndrome and consequently in preventing potentially fatal hypoglycemic episodes. Like cause awareness of this syndrome is essential for a correct pre- and intraoperative management of the patients. In all 3 cases we had in our center in the last 5 years, the diagnosis of achalasia has been crucial for a complete diagnosis of the syndrome. A laparoscopic adermatiotomy plus Dorfman duplication was performed in all 3 patients. Overall symptoms substantially improved in the short-term follow-ups, and no esophagitis were detected 12-month endoscopy. So this treatment confirmed to be safe and effective. Thank you.
Question or comments from George? Okay, thank you.
So we move on to the next one, which is esophageal perforation during cardiomyotomy laparoscopic management by Kaya Kumar.
Good afternoon, everyone. Laparoscopy has become a preferred approach for Hellas myotomy, but it is not without its complications. I present a case of 12-year-old boy who presented with complaints of difficulty in swallowing food and vomiting. He was malnourished at the presentation. On investigation, on contrast study, he had a dilated esophagus with distal narrowing, and endoscopy confirmed the findings of achalasia cardia, showing a narrow, non-relaxing distal esophagus. Hence, we performed laparoscopic Hellas myotomy for this patient. Intraoperatively, while performing the procedure, the esophagus was injured, and you can see here a full thickness mucosal injury. We repaired the mucosal defect using absorbable sutures. We placed an omental patch there and finished the fundoplication. The postoperative recovery was uneventful for the patient. To conclude, laparoscopy is a safe procedure for Hellas myotomy, and even in case of complications, they can be managed in a minimally invasive way rather than converting to an open procedure. Thank you.
Any questions? Thank you very much.
Next paper is mine.
Yes. Hypertrophic various stenosis mania excluding gastroenterologist and unit presentation. Please, Doctor.
I am presenting a rare case of gastric outlet obstruction in a unit. My patient was a term-born, exclusively breastfed baby boy. For 15 days, he had complaints of vomiting, and at the time of presentation, he had worsened symptoms and inconsolable thirst. On examination, the patient was severely dehydrated and had an upper abdomen distension. We initially resuscitated the patient and put an NG tube for drainage. On investigation, in the contrast study, there were features of gastric volvulus. The contrast study here shows that the stomach is dilated and the G junction and the pylorus are close by, suggesting an organoaxial volvulus. And ultrasonography was suggesting a normal thickness pyloric muscle. At this point, we considered gastric volvulus and operated the patient. We performed a laparoscopic gastropexy, but post-operatively the patient had persistent symptoms. Hence, we proceeded for an upper GI endoscopy, which showed a narrow pylorus, which was stenotic and not distensible. Considering the diagnosis of non-hypertrophic pyloric stenosis, which is a rare diagnosis, we performed a laparoscopic Henniken-Nicholas procedure. Post-operatively, the recovery was uneventful and he was discharged after 3 days. It's been 6 months since the surgery and the patient has been asymptomatic. To conclude, NHPS should be one of your differentials considering the gastric outlet obstruction. It is a rare diagnosis and it should be done only after ruling out the other causes of pyloric obstruction. Thank you.
You certainly studied the literature. Do you think, or do you find that a gastric volvulus is a typical finding accompanying NHPS?
No, but the gastric volvulus was masquerading the actual etiology of non-hypertrophic pyloric stenosis. Hence, it was missed initially.
Any other comment? Thank you.
Then you can move to the next presentation with factors for symptomatic presentation of megacerebral irritations. Dr. Massier from Barcelona State.
Hi, good afternoon. The aim of our study was to identify the risk factors of symptomatic presentation of a metal versiculum, providing its characteristics, the length, the width, and the presence of ectopic mucosa. We performed a retrospective transversal study of the patients operated on our Center of Metal Diverticulum Resection from January 2009 until August 2021. We included 93 patients with a median age of 4.2 years old. The presence of ectopic mucosa was a risk factor for bleeding and perforation. We also found out that the length was a risk factor for torsion and intussusception, and the width a risk factor for perforation, intussusception, and the presence of ectopic mucosa. So we conclude that the presence of ectopic mucosa and the level and microfibraticulum characteristics increase the risk of symptomatic presentation. And when dealing with a large or wide incidental microfibraticulum, prophylactic resection should be considered to prevent future complications. Thank you.
Questions or comments from the floor?
Diagnostic challenges in the screening of birth rate, premature infants with suspected esophageal atresia, a case report by Francesca Consi.
Good afternoon, everyone. I have the pleasure to share with you the case of a 410-gram premature born baby where the failed attempt to insert an NG tube and the following X-ray images pose suspicion of a type C esophageal atresia with perforation of the upper pouch. To assure diagnosis, we performed a tracheal bronchoscopy with a 2.3 milliliter flexible bronchoscope, and as we failed to find a clear trapezoesophageal fistula, we proceeded to scope the esophagus. In absence of adequately sized gastroscopes, we used the same flexible bronchoscope and insufflated air via simultaneously advanced NG tube for French. Once the stomach was reached, under visual guidance, we could exclude the diagnosis of esophageal atresia and leave the NG tube in place to treat the esophageal perforation, which healed with no further complications. Esophageal perforation is indeed a rare but known complication of NG tube placement in extremely low birth weight infants, and due to the shared clinical and radiological features, mistaking this diagnosis with esophageal atresia is plausible and needs to be taken into consideration. We therefore advocate for a mandatory endoscopic evaluation of the esophagus and of the trachea before diagnosis, and in case of extremely low birth weight children, sometimes creative workarounds are necessary to this end to meet the need of these demanding cases. Thank you.
Thank you very much. I think this is an excellent presentation and presenting that it was managed conservatively. Did you additionally place a suction tube in the pharynx to evacuate saliva?
No, it was not necessary, which could have been a sign that it was not esophageal atresia probably, but no, it was not necessary. So no one was found.
And alternatively, you could have just placed a gastroscopy and decompressed the stomach and nourish by that without doing that procedure?
We could have, but it would have been more invasive. So we just did the trachobronchoscopy in the same settings we were prepared to do a ligation of the fistula and a gastrostomy, so the setting was already there. But as we did not find the tracheoesophageal fistula, we thought maybe the diagnosis was not the correct one, and then we proceeded to scope the esophagus.
Thank you.
Thank you.
Now we move on to the next presentation, laparoscopic gastric transposition for long-acting esophageal atresia, report of 50 cases done in India. Dr. Leonardo.
Good afternoon. Recent trends in long-acting atresia has been on preserving native esophagus. However, the expertise on that is limited even in developed countries. In our centers, all these children inevitably undergo a cervical esophagoscopy and a feeding gastrostomy effort, which then necessitates esophageal replacement later in life, which is usually a gastric conduit done through the transhiatal route. This is by now usually done by open method with combined laparoscopic and laparoscopic approaches being reported in a couple of centers. We had 2 children with type A and type B atresia who were diverted at birth, and we then did a completely laparoscopic gastric pull-up for both these children. The transhiatal dissection was done under vision and the stomach mobilized and taken up for leg for the anastomosis. Both of these children are doing well at 6 months follow-up. These are the first 2 cases reported from our country. In cases where esophageal replacement remains a predominant treatment modality for long-gap atresia, laparoscopic approach can provide a safer option and a less morbid option till laparoscopic primary management of these conditions becomes feasible. Thank you.
In the first 6 months of postoperative period, you have enough gain weight. Do you have a special feeding regime postoperatively? Because generally these patients suffer from weight loss in the first year of postoperative.
Yeah, so since as I said, most of our patients, these patients undergo esophageal replacement, do a lot of gastric pull-ups. So we have a specific diet regimens and management for them. But it should be open for the first time laparoscopy. So there are specific regimens to manage. We start championing before we give the regimens to the parents before we give the surgery to train them.
Thank you. The next one is uses and applications of capsular endoscopy in pediatric age, analysis of 10 years experience in a single center, presented by Julian Thomas.
Good afternoon. We present our last 10 years experience with capsule endoscopy. And during the study period, we performed 71 exams. And in our series, there were 29 positive cases, and the most frequent localization of the pathological findings was ileum, followed by duodenum and jejunum. Our indication to perform a capsule endoscopy were recurrent abdominal pain firstly, followed by rectal bleeding, follow-up for hereditary polyposis, positive fecal count blood test, and IVD. The pathological findings were ulcerative lesions in 20% of cases, followed by macula diverticulum, polyps, inflammation, and aphthous ulcers. In conclusion, we can say that capsule endoscopy is a safe and effective diagnostic tool detecting anomalies where other exams like breast endoscopy or radioactive scan were negative. Thanks.
Thank you very much. A few questions. What age would you consider to be appropriate for children? And what is your parameter? Is it weight or height or whatever? And the second one is, what happened to the slug CE? What happened to the slug CE?
Okay, so in the literature, the smallest patient was 8 kilos and 8 months. In our series, the smallest patient was almost 2 years, because maybe baby can swallow voluntarily the capsule when are 10, 11, or 12, or you can push by endoscopy if they are too small. But since 1 year old, you can perform this exam. And the second question?
What happened to the patient with the slug CE?
With that?
There's one patient where the CE ball got stuck in the ball.
You can perform a patency capsule to check if there is some stenosis or obstruction, to check if there is some obstruction in the bowel. And
how do you get it out?
What?
How do you get it out of the bowel? It got stuck.
Yeah. You can evacuate the capsule.
You had one patient where the CE ball got stuck in the bowel.
For a capsule in Casaccio. We remove by coloscopy.
Okay.
Sorry.
Thank you.
Thank you.
We have more in the presentation, a different method for gastrostomy, laparoscopy for the gastrostomy from Dr. Daniel from Turkey.
Can you change it? Not that long. Is another presentation?
So can we continue with that presentation? So okay. So we can continue. Thank you.
Our gastrointestinal surgery can improve
Beni kesilmediler.
patients, preliminary consideration in series of cases. Dr. Rosary.
Okay. I present our preliminary consideration in these 12 patients that with asthma that we treated between 2020 and 2022. These patients presented malnutrition, dysphagia, and gastroesophageal reflux. All patients underwent PEG, and in 11 patients we performed a laparoscopic fundoplication. In our preliminary results, we can see an improvement in management and quality of life for all patients and weight gain. We want to underline the importance of avoiding malnutrition. Malnutrition is related to delayed palatal development, orthopedic issues, and increased morbidity and mortality. To avoid malnutrition, it's important to establish the best time for surgery, and to do that we need a multidisciplinary approach in order to reach our purpose to perform a tailored surgery for every patient. Thank you.
So one of your patients got a gastric detachment. How do you explain it? You got a pen?
Yeah, because
gastrostomy?
Because this particular patient was in a very severe malnutrition status at time of PEG, and when we changed with the first tube with the the low profile is positive, we have this communication. Thank you.
So now we should continue with presentation 59, is that possible? Apparently it's not possible. So can you please load the next presentation? Okay.
Special surgery in children with aortic malformation. Dr. Joseph from Hospital Russian.
Dear President, dear colleagues, this is presentation about early surgery in children with aortic malformation. We used another non-randomized uncontrolled study was conducted, including 47 patients with IRN who had previously undergone digital surgery. The methods of visual examination, MRI, ultrasound, X-ray studies were used in the examination protocol course. In the results, 10 patients, 6 boys, 4 girls, underwent radical posterior surgical approach, for angioplasty instrumentation. 9 of these girls underwent perineal reconstruction under post-penicle therapy. 3 patients with complete rectal prolapse underwent transmural rectal lipodectomy and muscular application according to the rectal certification. Anastomosis was discovered in 15 patients. 4 patients of the group were operated for the resection of the distal colon in the absence of the effect of the DNASH with the development of pathology limited megarectum. We have performed operation in for 6 boys with the original fistula through having excision of the roof for all patients without the needle laparoscopy. 4 patients with the retraction of the rectum under the SAR after primary procedure by laparoscopic assistant operation. Conclusions. Reoperation in patients with ARN associated with technical defects in primary operations. The absence of electron identification during the primary operation, high processing of distal colon with some depth rectal fistula, absence of circular release of reduced distinct from them, along with their culture.
Question from the floor. Just one question. What is, in your opinion, the main criteria to perform a protective colostomy?
To perform it?
Protective colostomy.
It's an individual in a whole face with
Laparoscopic procedures in children of the first 6 months of life malnutrition syndrome without clinical focus.
Yes, the indication and timing for surgical treatment of intestinal malformation syndrome in children during the first months of life without needed bolus have not been determined. Some surgeries prefer open legs operation in patients with rotation environment without clinical manifestation of obstruction. While other offer surgery only clinical signs of recurrent duodenal obstruction without. We performed laparoscopic procedure in 5 patients aged 3 weeks till 6 months with clinical manifestation of recurrent duodenal obstruction without interfocus. Laparoscopic LEDS procedure was successfully completed in all patients without conversion to laparotomy. The average duration of surgery was 90 minutes. The average length of hospital stay is 8 days. Anterior feeding was restored in 8 days after surgery. The symptoms of duodenal obstruction completely resolved in all patients. Laparoscopic procedure is a safe and effective procedure that can be performed in patients with clinical manifestation of malnutrition without immediate bolus in order to prepare for
Thank you. Question, combination of extrinsic and intrinsic obstructions are not rare. So did you do an endoscopy for the operation? And how did you rule out the malrotation? X-ray or endoscopy? Was it X-ray? Thank you very much.
Then we can move on to the next presentation, outcomes of pediatric endoscopic hernia series treatment and systematic review from the United States.
Hello everyone, thank you for the opportunity. This is a work from Cambridge, United Kingdom. Motivated by the setting up of a new service for PEPSID in our institution, we conducted a systematic review again to summarize and evaluate for the first time the overall reported outcomes of PEPSID to date. A technique first introduced in the pediatric population in 2017 by Professor Esposito. We included a total of 320 patients from 9 eligible studies as per our inclusion and exclusion criteria. In these patients, the overall success rate was 91%, with a mean time to full healing of 4 weeks. The overall recurrence rate was 9%, with a mean time to recurrence of 4.6 months. We also compared PEPSID's non-invasive benefits, which mostly had to do with a short hospital stay, the minimal post-operative pain, and the fast return to regular activities. Despite its limitations, our study offers a more precise estimate of the overall effectiveness of PEPSID than individual studies alone, and therefore aids evidence-based surgical decision-making and counseling of families and patients. Of course, comparative studies are required, particularly against the best among the conventional techniques in order to be able to prove superiority of PEPSID. Thank you.
Much for sharing these results with us. Any questions from the floor? No. Thank you very much. Everything was clear.
Thank you.
Pediatric endoscopic sinus treatment for first 100 cases. Presented by
Directors from Boston State.
So, good afternoon. Pediatric endoscopic pilonidal sinus treatment has a favorable short-term outcomes, but there's a lack of reliable data on medium and long-term follow-up. The objective of this study was to evaluate the effectiveness and advantages of PEPSID versus conventional surgery of pilonidal sinus in the pediatric population of medium-term follow-up. So we performed a quasi-experimental study in pediatric patients between 2019 and 2022 at our institution, comparing excision and healing by secondary intention, excision and primary closure, and PEPSID. These are the different variables we have studied, and we found a significant less time of hospitalization, a significant less pain, so shorter painkillers required, and a shorter recovery time. So endoscopic pilonidal sinus treatment is effective in medium-term follow-up with less complications than classic techniques, and it's allowed for early return to normal life without restrictions. Thank you.
Question on the topic?
Thank you very much.
We can move on. Creating target endoscopy will can be the reason of recurrence that get from the
Okay, let's see the problems with the PEPSID. So our aim was to evaluate the complications and the recurrence following this procedure. We performed a prospective observational study, and we started this procedure in 2019 in our institute. So we studied the first 3 years of the procedures. The follow-up time was 1 year. It was a personal consultation or online because of the COVID, and we excluded all the lost patients. We studied the length of hospital stay, complications, recurrence, wound healing time, and the post-operative hair removal. We performed 43 PEPSIDs, including 4 redo procedures. The majority of our patients were male. The length of stay was 1 day only. The wound healing time was 6 weeks in average, yes, and we observed 2 wound infections and a high recurrence rate. But 19 patients had an inadequate postoperative hair removal, and it's very important that all the recurrent patients were in this group. But we like this procedure because the wound is very small and painless, and we can conclude the main reason of recurrence following PEPC procedure could be the insufficient hair removal. And unfortunately, in Hungary, the laser epilation is not financed in public healthcare system. Thank you for your attention.
Questions or comments?
Is it advisable to do the hair removal before any kind of surgery of sinus splenomegalis?
Yes, I'm sure in that. So we have so many patients who had an appointment for the surgery and performed the laser epilation, and after there is no symptoms, so there is no surgery. And now we have so many non-compliance patients, and if somebody cannot do the laser epilation, we don't do the surgery now, because there is no compliance.
We can move on to the last presentation. A different method of for gastrostomy, laparoscopic gastrostomy from Dr. Daniel.
Good afternoon again. I want to share our new technique for gastrostomy. In this method, under laparoscopic vision, the orgasmic tube was dressed and the needle was inserted through peritoneously through the previously determined site into the orgasmic tube, and the guide wire inserted through the needle and it was taken out from the mouth, and it's knotted with the catheter, and it was pulled out of the abdomen, and with the laparoscopic vision we can see the abdomen wall, and there is no another organ, and we can see here the appearance of the skin. And there were 22 patients of us, and no complications were observed in any of the patients in the first 3 weeks. And we say that this method is a safe and easily applicable, and with the laparoscopic vision, maybe we can prevent all major complications. Thank you.
Thank you very much. Was it always easy to insert a neutral grade E, or did you have any wiring or coiling of the wire? Did you have any coiling?
There is no problem for us to grasp it and the needle through the orgasmic tube, and then we inserted it, the guide wire, and take it from up.
Okay. Thank you very much. Okay. I think we finished the session. Slightly late, but also due to some technical